and the community. And here, when I'm talking of the community, we both have a local, a regional, and global audience. Thank you very much. To the presenters and moderators, I appreciate the time you have taken out of your busy schedules to unravel the coming of age and what we must all do. But we must have some housekeeping rules. So all presenters, you have your presentations. You should actually have 20 minutes allocated to you. Please confine yourself to those 20 minutes. And we will be rapporteuring, specifically myself will be rapporteuring on behalf of the moderators. Please let us all mute our microphones if you're not speaking. If you're not sharing PowerPoints, we may request that you may put on a video if you are comfortable with that. After each session, ample time for discussion shall be provided, but in the meantime, because we will gather all the questions together, we will address them at the end of the session. So please, if you have a directed question for a given speaker, put it as such in your chat box below and the Q&A. Those will be addressed after we finish our sessions. If you must speak, please raise your hand, and our request is only ask one question per person and be concise. The program will be shared daily, and even in between the sessions that we do hold, we are actually screening them so that you know the topical issues we will be discussing. This afternoon, it is hot and hot. We'll be looking at menstrual health management. We'll be looking at HIV. We'll be looking at family planning, and we will be looking at mental health and drug and substance abuse. I take this opportunity to welcome each one of you. There will be CPD points awarded. And for those who can't get CPD points, we will give you certification as per your registration. Thank you so much. I want to hand over to the two moderators for this afternoon. We have Professor Ruth Duarte, who is with us from the University of Nairobi Pediatric Department. And we have Dr. Lucy Kabare, who's also with us from the College of Health Sciences Medical Institution. Thank you so much.
Thank you very much, Dr. Kihara, for the introduction and setting the ground rules. I'm excited to actually be part of this forum talking about adolescents. Adolescents are shared between adult physicians, the OBGYNs, and the pediatricians. So it's a point of convergence, and I think it's good that we're having this meeting today. Now, you had kindly requested that we allow a talk that was left over from yesterday. I would like to use my discretion as the chair of this session and actually ask that Dr. Catherine Gogi speaks first. Dr. Catherine Gogi is the head of NASCO, a very, very extremely busy docket. I'm not even sure we'll have her for the whole afternoon. And if we could have her make her presentation, then Professor Elizabeth Bukusi, then we can slot in the presentation on sanitary hygiene as a third talk this afternoon, if you don't mind. So at this point, I will introduce those first three talks, and then I'll hand over to Dr. Kabare to introduce the next three, Prof. Geshenge, Dr. Joguna, and Dr. Josephine Omondi. All the panelists are my good friends. We've worked together for many years. And I know many things about them, but we shall not disclose everything here. Just to say they are very committed to this area of HIV, STDs, adolescent health, and really just human health. So, Dr. Goge, are you on board? Are you ready to start? And to talk about adolescents and youth and STIs and HIV.
Yes, Prof, I am. Maybe we can be allowed to share.
Yes. Thank you very much. Thank you very much for finding the time to be here and to present and to share with us.
Thank you, Prof, for the kind words. And at the same time, I really want to appreciate Dr. Kihara for the leadership on this very, very important topic. Honestly, knowing when we have looked at the data in the country, it's quite disturbing, knowing that our biggest percentages that we have in the country in terms of population is our adolescents and young persons. So I have a short presentation, and on behalf of the team from Ministry of Health, and specifically from NASCOP, being able to look into the data. More so, I will just be presenting on the data, knowing that this will elicit discussions and be able to provoke our thoughts in terms of the data where we are and in doing in the country. In terms of the HIV situation, I think all of us being in the field of HIV, we know the prevalence, we are at least 4.5%, but we have variation between male and females. But on this slide, so much I want us to concentrate on the part of the adolescents and young people. Noting that we have around, in the estimates, we have around 91,000 adolescents between the age of 10 to 19. There's usually a bit of overlap with the young adults. We have around 145,000. However, in the year 2020, we had around 6,166 new infections among the ages of 10 to 19. And 15 to 24, we had 14,410. But to disaggregate and really know the data that we have and look at it in a manner that maybe a normal Kenyan and a layman can understand, is that out of the more than 15 years old adults who got infected in the year 2020, 61% of them were between the ages of 15 to 29, which is very, very disturbing. In normal cascade in the country, I like looking more of overall adolescents and adults, and then adolescents and then children. That's how we are performing. And at 2019, our cascades were 90, but last year we revised it because we have somehow attained to 95. We want to attain 90, so now we have pushed 95 to 95. But if you look at the first 90s, especially on children and adolescents, and even the adults, we are really not doing well. We have not been able to identify the ones who are positive. And as well, unfortunately, the ones we have identified, we are not 100% able to put them on treatment. And as well, unfortunately, even though we have medication, in exception of the children, that can be able to help us attain the viral suppression, we are at around 70-something% involving adults and adolescents. In pediatrics, it's a different matter, but we know we are really working on it, especially the different molecules that we had in the country. It was hard, but at least within the next 6 months, we'll be able to, we hope we'll be able, when we introduce the new treatment regimen of pediatric DTG 10 milligrams, then we'll be able to attain it. Within our country, the first 90 of the people who know their HIV status, that's how we are. Noticing that only a few counties have been able to get to 90%, and quite a number not being able to meet the mark, as well as nationally, that's where we are. Viral suppression on the same rate in terms of the country, only a few counties have been able to attain at least over 90% of all in terms of uptake and not cascade. But let's look at what is really important in this symposium on adolescents and young adults. In the year 2020, we had between the ages of 10 to 19. That's how we performed in a country in terms of all the adolescents between the ages of 10 to 19 who were tested for HIV. That's how the counties were performing in terms of how many tested positive. And as well as you can see, there is in terms of like the prevalence and the new HIV infections, it's somehow like in tandem. But we hope that even when you go to the next slides, you would note as well, not only it is in the young adults or adolescents, but as well as even in the males and females. And as well, the new HIV between the young adults as well, in terms of the numbers, you can see it is quite a bit very high, which is a bit sad. Now, putting it together for adolescents in terms of, and I think we have another presenter who will look into this, but as well, we usually look at it in terms of in NASCOP, because we know that when we look into new HIV infections and teenage pregnancies, they somehow tally. And where we are, and all of us being public health experts, we cannot look in one vertically only on HIV, but as well, we know that this client, these adolescents, these teenage, this young adult has other matters. How did they get that HIV? Definitely, there was no use of condoms. So then teenage pregnancies comes in. And then if the teenage pregnancy comes in, then mother-to-child transmission of HIV comes in, because then if this young adult is not able to access the services because of either stigma, discrimination, or not able to access the services, there is, I know it affects, the roller coaster affecting several other outcomes within the health within the country. So Department of Reproductive Health and NASCOP, we are somehow really affected in the indicators that we have. And so we really look into specifically in terms of the maternal deaths, as well as the pregnant and adolescents who are there, who are recorded with somehow the same number that we have for the pregnant adolescents that year. It's almost equal to the new HIV infections we have, and as well as further to the mother-child transmission of HIV we'll have within that year. So there is a way that one affects the other. In terms of trend as well of teenage pregnancies, you can note, even though you note that the number reduced in 2020, but I think it was more of underreporting, because when you have gone to the field, when you look into the being able to put to the numbers to the faces, they are very, very quite high. And I think Patricia yesterday was able to give an example of where we have been able to visit in the country, in some of the areas, and what we have noted there. And I know the other presenters, especially in the field, will be able to explain more on this. I think I alluded to this in the discussions in terms of the new HIV infections, but I think more so is looking into the teenage pregnancies and the new HIV infections. I think it's another slide will be shared by Dr. Masha when she's presenting in the, I think on Friday, how those two are being tied together, and how if we are able to deal with the teenage pregnancies, then we are able as well to deal with the new HIV infections, because the two are working hand in hand. But at the same time we note that even where we are noting there's a high teenage pregnancies, with the new HIV infections, it's the same areas we have high HIV prevalence. And as well, the areas that is being able to be dealt with, for example, in Muranga County, I think Dr. Mbai will be explaining to it in one of the discussions later, is that where the leadership has been able to take up that, then we are noticing reduced new HIV infections as well as the teenage pregnancies. This is a trend as well, new HIV infections, and times this is comparing. We wanted to do comparison of the different years, and you can note that it is increasing from 2018, 2019. There's a bit of stability in 2020, but we know, as I have said, that we have noted in last year there was underreporting of the numbers of the several indicators in the counties. In terms of the adolescents who've been able to identify and put them on treatment, is that's the same, that's how we are doing in the country. Unfortunately, when you have the linkage between the first 90, the second 90, and the third 90, we have a D-link between the first and the second 90. We are able to identify them, but unfortunately, because even though we have the test and treat guidance in the country, we are not able to put 100% of them. So there are other factors coming in, stigma, discrimination, denial at the same time, and as well as other stakeholders who are supposed to play a very key role, especially on within the education sector, and as well as within the faith organizations. But as well, missing the point of teaching about abstaining and among our adolescents, and the benefits of abstaining, or even for the ones who are more than 18 years old, being faithful or using condom. Really is not happening. But more so, abstaining is an area that we have really forgotten as a society. And it's an area I would wish, as we go on with Dr. Kihara and the team, that we may be able to discuss it with assertiveness in the country, that we still recognize that abstain is one of the interventions and strategies, especially among our adolescents and the young adults, and the benefits for it, not only for HIV, but as well as issues with cervical cancer and the likes. The same, young adults who tested positive. And you know, when you're talking about young adults, these are the ones that in their thinking is quite totally different in how they are thinking and how the different strategies. In one of the forums, I had a discussion with them, and they were quite dismissive of like, abstain, be faithful. They were like, doc, stop giving us condoms which are not dotted or illuminating. For heavens, sure, I did not even know what illuminating was. But that's an area that I think as well that we put them at the table when we are discussing on the intervention and strategies to be used on that cohort and the population. So then can be able to work, because when we have put in the strategies and the interventions we have used for the last 10, 15, 20 years, somehow we are not getting results. And I think for us, as we have agreed with the National AIDS Control Council, as NASCOP, and in general, the Ministry of Health, there's need for us to go back, retract, and see how do we define new strategies to address holistically and comprehensively about adolescents and young persons in the country, knowing that they are our future, and so more than we are endangering our future generation. As I conclude is for us, you can notice the first 90-second 90 in terms of by December 2020, as I have said, we have revised our target to 95, 95, 95. That's where we are in terms of missing on the first 90, around 16,000 of them we have missed to identify them. As well, we have missed on the ones we have been able to identify. That is in comparison, in knowing your denominator is the estimation we have of the 91,634. And then the last 90 in terms of the ones that have been identified, there's not consistency. Issues to do with that adherence and retention are still a gap we have in the country. And especially this COVID-19 is really not helping, because there are many interventions and we had put in place to working with the education sector, developed guidance to see how we can ensure, even though we have clients who are HIV positive, how do we ensure that they still continue taking their medication, and as well the ones who are in day school, innovations of having them on Saturdays be able to go for their clinics so they can be able to attain and access their medication. This is for the young adults, still the same notes gap, 65, 65, and 57. And that is all we have from NASCOP. We have not put in terms of what we are doing, but I really wanted us to elicit with the data that we have, what the performance, not only at the county level, but as well at the nationally, and see as we conclude, what can we put in place. Thank you very much, and over to you, Professor Ndwati.
Thank you very much, Dr. Ngugi, for a very, very succinct presentation of the state of adolescence. I couldn't help but identifying that the city of Nairobi is on the list of a city that is dangerous for adolescents. And I also couldn't fail to notice Homa Bay, especially your slide on number of new HIV infections, 665 in a year, in a population of 1.1 million people. This is quite contrasting with the 599 in Nairobi, in a population of 4 million people. So let's think, just to add the provocation, that let us think, what does this mean for our people, for our communities, and our neighborhoods? Now, let me now invite, for people who have questions on Dr. Ngugi's, Dr. Ngugi, are you going to be able to stay on until the very end?
Yes, Prof, I'm available. Okay,
super. So please, if you have questions, hold on to them or even post them on the chat box and we'll pick them up. Now I want to invite Professor Elizabeth Mukusi to talk about PrEP and PEP. Now, PrEP and PEP is something as Kenyans we should own. We were the site of very important studies on couple studies to find out whether PrEP and PEP work. Randomized trials were done among couples, discordant couples. And I know Elizabeth was one of the PIs for one of the sites. The other PI was Dr. James Carey, who's now heading reproductive health research at WHO, Geneva, and Dr. Nellie Mogul, who's one of the senior Cambridge scientists, was a coordinator for these multi-center studies. So the data from these studies, we should own it. This is our own people who are participants, who ran the studies, and who now have informed the policies that we have. I am also aware that there's some very important demonstration projects that were done around TICA, again, on the particularly on the both PrEP and PEP. So Prof. Bukusi, Prof. Elizabeth Bukusi, please go ahead with your presentation. Thank you.
Sorry, Prof.
Yeah. Oh,
I'm seeing
Dr.
a message being sent. Sarah Gitome is going to present on behalf.
Okay, that is very nice. I think this is also a demonstration of the versatility of Professor Elizabeth Bukusi. She has trained a whole team, built their capacities. So thank you very much, Dr. Sarah. Please present. We look forward to your presentation. Thank you. And I like your last slide. Yeah.
Thank you very much, Prof. Nduati and Dr. Kabare. Yes, I was just going to start off by saying that I'm making this presentation on behalf of, or in place of Professor Elizabeth Bukusi. She sends her greetings to everyone. So I have been working with the Kenya Medical Research Institute for over 12 years now. And my focus has been on HIV prevention research and reproductive health, sexual and reproductive health. So as a disclaimer, I am not an expert in adolescent sexual and reproductive health, but through my research, of course, I've had opportunities to interact and engage with adolescents and young women. And I'll be sharing some of the insights from this work, as well as what is already known to hopefully most of you. So I hope I'm the one who is sharing. Is it possible to be allowed to share my presentation? I think somebody else is sharing. Thank you. Okay. So I know, and I thank my previous co-presenter, Dr. Catherine Ngugi, whom I've known for many years. She has given us the reality of what's happening with our adolescents and young people when it comes to HIV. And I must say that it's very saddening. But I want us to start off on a light note and to acknowledge and remember how beautiful youth is. And I'm sure we've all been youths, or maybe some of you are still youths, but I'm sure you can remember with a lot of nostalgia the days when you thought you could do anything and you could achieve anything in the world, and all barriers were surmountable. So this is the group of people that we're talking about that we need to protect and to preserve so that we have a future. And I know it's saddening for all of us to just think about this startling statistic that globally, 1 in every 3 new HIV infections are occurring in a young person. And young person here, we're talking about people who are aged between 15 years and 24 years old. So adolescents and young adults. And this is a really saddening statistic that ought to make us think about what are we doing and what can we do differently to change this. And we know that adolescent girls and young women continue to bear an excessive HIV risk. In sub-Saharan Africa, 80% we have 80% of all women, young women who are living with HIV. They reside in sub-Saharan Africa. And you can see that that is a really huge burden for the continent, given that most of our population is young. And these are the people that we're looking forward to raising to become our leaders tomorrow. Closer home, and I admit that these statistics might be a bit out of date. Dr. Ngugi's presentation has more current statistics. But again, it's just a reminder that young people are now contributing a majority of what we call the adult new HIV infections, as much as 40%, probably even more. And when you zoom in on this, 1 in every 5 of these new HIV infections are occurring in adolescent girls and young women. And adolescent girls and young women are particularly vulnerable to HIV because of a lot of factors that I will not really go into details about, but we know that biologically they are more vulnerable than their counterparts, gender. Then in terms of social and cultural issues that put them at risk of HIV, we know that there are certain practices that put adolescent girls and young women at risk for HIV, and also the way society treats adolescents and young people in general. They are not really supposed to have a voice, so they don't even have the space to articulate their sexual and reproductive health needs. They may not even be aware what their sexual and reproductive health needs are or should be, and what kind of services they should be seeking. At the same time, we know because they are young, they're still developing, they're still not able to, they're not able to assert themselves, and they are dependent on others for financial or any other kind of upkeep, because they're not yet at a point where they can earn money and take care of their basic needs. And again, a lot of these adolescent girls and young women come from very poor backgrounds. So there are certain things that put them at risk for HIV infection. Now, most of the HIV prevention options that we have, or that have been there for a number of decades, are not quite realistic for adolescent girls and young women. One that we know is highly effective and works very well is abstinence. But we know because of the disempowerment among adolescents and young women, or adolescents in general, they may not be able to assert themselves and say that, you know, I'm going to abstain. And especially in situations where they find themselves in a relationship with an older partner, they may not be able to assert themselves and say that they want to abstain in this relationship. And again, faithfulness, they may be faithful on their part, but if their partner is not faithful, then they're still at risk of acquiring HIV. Similarly with condom use, we know that this requires negotiation skills, especially if you're using the male condom, which is what is most available to most people. But even when you're using the female condom, because it's not a discrete method of HIV prevention, you still need to get some partner cooperation for that. Of course, more so with the male condom, where the male partner is the one who's wearing the condom. Then for adolescents and young women who find themselves in relationships with HIV-infected partners, treatment as prevention we know works, HIV treatment that is, but it relies on the partner to take the medication consistently and correctly, and to be motivated to continue taking this treatment for a long time so that he can remain virally suppressed. So you can see for all these methods, the underlying factor is that the adolescent or the young woman is relying on somebody else to implement these prevention options. So are there other HIV prevention options that adolescent girls and young women can use? You'll realize that for the most of this presentation, my focus is on AGYWs because they are the face of the pandemic right now. But of course, a lot of these methods can also be used by males, adolescent males who are at risk of HIV infection. So we'll look at each of these methods for the rest of the presentation. And I'll start off with what I know most of us know about, which is the oral pre-exposure prophylaxis, or in short, oral PrEP. This is a method of HIV prevention where somebody who's HIV uninfected takes a daily pill every day to prevent HIV in acquisition. So this is somebody who's HIV uninfected, but they are at an ongoing risk of acquiring HIV. And they take this pill daily, consistently, and they're able to prevent HIV infection. So for instance, somebody who's in a discordant relationship would be a good candidate for this kind of method. Or even somebody who, not necessarily in a discordant relationship, but maybe in a relationship with somebody who has high-risk sexual behavior, or they themselves are involved in high-risk sexual behavior, then they would be a good candidate for this method of HIV prevention. It does require high adherence. So the person needs to be able to take this medication on a daily basis, around the same time every day, and for as long as they are at ongoing risk of acquiring HIV. And there's need for regular risk assessment to see whether somebody is still at risk and hence in need of continuing with the medication. And this can be done at a health facility easily. So this is what I just said. What I wanted you to note here is that for what we most know about is Truvada, but there is also another drug called Descovy. Truvada is TDF, tenofovir, disoproxyl fumarate, and emtricitabine. And Descovy is another version of tenofovir. Tenofovir, I can never get it right, but it's TAF and emtricitabine. But what is registered in country is Truvada, and that's what is in use. So let me just show you a short clip about how PrEP works in case, just as a refresher. Sorry.
Let's start with how HIV infection happens. HIV typically enters the body through unprotected sex or sharing injection drug use equipment. After HIV has entered the body, it targets the CD4 cells in the immune system and begins to replicate within them, creating millions of copies of itself. These copies then go out into the body and find more CD4 cells and use them to make even more copies. The immune system tries to stop the cells from multiplying, but if the immune cells can't keep up, the HIV infection spreads to other parts of the body. At this stage, the infection becomes permanent. Now, back to how PrEP prevents HIV. When a person starts taking PrEP, the drugs reach high concentrations in the places where HIV can enter the body, such as the bloodstream, genital, and rectal tissues. The drugs prevent HIV from making copies of itself in CD4 cells. Since HIV can't replicate, the immune system can clear it from the body, preventing a permanent infection. This is why it is so important to take PrEP as prescribed, to ensure there is enough of the drugs in your body to stop HIV from replicating. When a person...
So what clinical trials have shown is that oral PrEP or Truvada is highly efficacious if it's taken as prescribed. In the landmark trials that Kenya participated in, and we had a site in Kisumu as well as a site in Thika, they found that Truvada had an efficacy of 75%, meaning that the risk of acquiring HIV was reduced by 75%. And the other drug that was being compared in that trial was tenofovir, which also had a pretty good efficacy of 67%. But what advanced beyond this this trial was Truvada. And in latter trials, especially the kind of like real world setting trials, they found that people were even more motivated to take PrEP more consistently. So the adherence was higher. And in those cases, the efficacy went even above 90%. So that was a really good thing and an encouraging point in the HIV prevention journey. But we know that there are people who might find it difficult to take a daily pill. So is there an option for them? And luckily, very recently, a new drug that was under trial for this kind of pre-exposure prophylaxis was found to be highly efficacious. And this drug is Carbotegravir, which is a long-acting antiretroviral drug, belongs to the class of drugs called integrase inhibitors. They inhibit that specific enzyme called integrase, and hence they prevent the virus from multiplying and infecting multiple cells and establishing a systemic infection. So it's administered every 8 weeks or every 2 months, and it's an injection. So somebody just goes and they get an injection. You don't have to go home with any box of pills or tablets. And so in that sense, it's a discrete method. And what was really interesting about Carbotegravir is when they did a randomized trial comparing it to oral PrEP, in this case it was Truvada, and they found that it was 89% more efficacious than oral PrEP in women. So it was a great, great thing about Carbotegravir. We're not saying that oral PrEP is not efficacious, but some of the reasons for this were that because it's an injectable drug, it is amenable to higher adherence because somebody's just getting the drug. You don't have to remember every day to use the drug. And what we have found with all these antiretroviral drugs is that adherence is key. And then because it's discrete, women like it because they just go, it's like going for a Depo-Provera injection in the clinic. You just get it, you forget about it. You don't have to go and explain why you're having a box of pills to be taken for 3 months. And again, it can be easily integrated into existing health services, e.g. family planning clinics. And then another really good advantage about this is that this kind of method can be combined with other methods that address other sexual reproductive health needs like pregnancy prevention. Then there are women who may not want to take a daily pill or go for a regular injection. So for those, sorry, before I proceed, I forgot to mention that Carbotegravir is not yet registered for marketing. So they are under regulatory review for marketing approval. And we hope that that will come through soon. So in comes vaginal microbicides, which are, as the name suggests, are topical products, again, antiretroviral based, to be applied in the vagina. So the history about vaginal microbicides is really long, and for many years it was very disappointing. Lots of products were tried and none of them seemed to work. Actually, some of them put women at a higher risk of acquiring HIV. But this one microbicide, which is the dapivirine, was found to be efficacious. We'll look at what the efficacy was for this product. And what is currently registered for use is the intravaginal ring. But there were formulations that were in a gel form. That's what you see in this first picture. The applicator looked like this, but what we're using now is this dapivirine ring, and it has been registered for marketing. So again, it requires high adherence, like all antiretroviral-based products. The formulation that is in use right now is inserted once every 28 days. So the woman inserts it, she has it in situ for 28 days, and then after that, they change and put another ring, because the drug in the ring will only be protective for those 28 days. After that, the drug levels will be too low to be protective to the woman. So the active ingredient is a non-nucleoside reverse transcriptase inhibitor. It's inserted high in the vagina, as we'll see in the clip that follows. And in the clinical trials that were done, the side effects were mild to moderate, not really requiring cessation of use of the intravaginal ring. So these included vaginal itching, vaginal discharge, and such like. So let's see how it works.
Could soon help fill an important gap with a long-acting product that a woman controls herself and could use discreetly to reduce HIV risk during vaginal sex. A woman would insert and replace the flexible silicone ring each month, set it and forget it.
The ring sits inside the vagina, near the cervix, where it slowly releases an antiretroviral drug called Dipivirine at the site of potential infection. Dipivirine works by blocking HIV's ability to make copies of itself inside healthy cells. The ring must stay inserted to do its job.
So in efficacy, in clinical trials that were done among women, some people may consider this disappointing, but for those who've been in the field of microbicides, this was really, really exciting. The efficacy in the 2 landmark trials was 27% in one and 35% in one, giving an average of about 31%. But again, when open label extension trials were done, where the setting was more, like a real world setting, women were more motivated to use it, the adherence was higher, and the efficacy based on modeling was even higher than what had been found in the phase 3 clinical trials. It was at 50%. So this is exciting. Of course, there's no, microbicides alone will not end the pandemic, but we're just saying that there are more options now available to protect women and to protect young people from HIV. Now, the thing I want you to remember, and this is based on a lot of PrEP studies that have been done, is that adolescent girls and young women consistently seemed to have the lowest adherence during PrEP trials and even during microbicide trials. Microbicides is just another kind of a PrEP, but it's a topical PrEP as opposed to oral PrEP. So this was despite high awareness of the existence of PrEP, despite the adolescents knowing that they have high HIV risk, and despite even the availability of PrEP being freely provided and having very youth-friendly clinics where they could access these products. So uptake was low, and even when they take up the PrEP, they're unlikely to adhere. And like I said, lowest adherence and efficacy was found amongst the youngest age groups of women. This is just one of the studies we've done in KEMRI, or we participated in KEMRI. And here they were looking at AGYWs, 15 to 24-year-olds, who are being started on PrEP. And look at that. At 1 month, 43%, only 43% of these participants were still using PrEP. At 3 months, which is when they're supposed to come back for their refill, this had dropped down to 20%. So you can see there's a big problem when it comes to adherence to PrEP and continuing to use PrEP among adolescents. And some of the reasons for why AGYWs fail to initiate or continue with PrEP is that some perceive themselves to not really be at a high risk of HIV, even though when they do the scoring, you can clearly see that they are at a high risk of HIV infection. Then there's certain provider-related barriers where a provider may not be willing to provide PrEP or may come across as being a bit judgmental to the adolescent for coming forward for PrEP. There's a fear of the pill burden, low social support. They don't have people who can encourage them if they really need this PrEP to actually go for it. We talked about lack of empowerment. And then also, of course, in some areas, there's low awareness of HIV prevention options available. And you can see here that there's poor uptake of HIV testing among the adolescents, and especially the very young, the 15 to 19-year-olds. You can see only about half actually go for testing, and this could be related to their low perceived HIV risk. Some of the other concerns when it comes to AGYW are that most of the sexual debut experience is unplanned, and in some cases it's forced. So in such instances, it's going to be unprotected sex. And even when they are continuing in a consensual relationship, they are unlikely to be using condoms even when they are at risk for HIV. Then what we have seen in a lot of the studies where we're doing offering PrEP is that there's a high STI burden. Some of the studies you'll find as many as 21% have at least either chlamydia or gonorrhea. In some studies in South Africa, I think they found a high prevalence of STIs of about 50%. And then many cases, they have multiple sexual partners who they are not able to negotiate safe sexual practices with. And there's also a lot of peer influence, which we don't really understand how it just comes into play and interferes with uptake of some of these services. So AGYW's sexual and reproductive health risks are interlinked, as Dr. Ngugi put it so clearly, that where there's these unintended pregnancies, STIs and HIV follow. And that's why we're talking about what options can offer even better protection. Can we look at multi-purpose prevention technologies for this group, so that once they get one jab, they are protecting against HIV, they're protecting against other STIs, and they're protecting against unwanted pregnancy. Just to touch on post-exposure prophylaxis, this is triple therapy, where we use the same antiretroviral drugs that are used for treatment, but then they're taken by somebody who's HIV uninfected and has had a high risk exposure to HIV. So this should be initiated soon after exposure and for a period of 28 days. However, to note is that if somebody keeps coming back for PEP all the time, then this is somebody who should be canceled to take PrEP. So in conclusion, what I'd like to say is that we have a lot of HIV prevention interventions that AGYWs can use, but they need to be tailored to their complex needs. And I'm not just talking about biomedical needs, but also the psychosocial, the emotional needs. We need to think how to tailor these interventions so that they can be appealing to the AGYW and they can take them up. And a multiplicity of approaches is required. So behavioral, biomedical, looking at human-centered design, and how do we really identify what are the needs? How do we go deep into the needs of these adolescents and actually make something that they would want to use or to take up, including already existing interventions like abstinence and faithfulness. That's the list of references and acknowledgements. And I thank you all for your attention. Thank you.
Thank you very much, Dr. Itome. Very thought-provoking presentation. Very beautiful slides, very sobering facts. Thank you very much, and you've observed time well. We now have the next presentation, the third presentation, and this is the one we're slotting in from yesterday. I think it's appropriate. It's about the physiological needs of the adolescent girl. Before now we swing into the last three sessions of the day. So Dr. Janet Muller, if you're in, the floor is yours to talk about sanitary hygiene. Thank you.
Thank you very much, Professor Duarte. I am not Dr. Janet. Sorry, I'm Janet Muller. I work for the Ministry of Health. I request that Dr. Kihara shares my presentation because I had shared it with her.
Dr. Kinuthia, please take charge.
Yes, so thank you very much. So thank you very much for the opportunity to talk about menstruation. As all of us know, menstruation is a normal biological process, and it is a sign of good reproductive health. And regardless of this is a subject that has been taboo. Actually, it is shrouded with a lot of myths and misconceptions. It is a subject that usually is discussed by a specific kind of people. And in this case, it's supposed to be discussed by women. And so because of this, we have realized that there is a lot of problems in terms of access to information for not only adolescent girls, but even women. And we have other problems that are related to menstruation. So my presentation will be talking about what we have learned in the context of the pandemic. And so we know in Kenya, we are in the midst of the COVID-19 pandemic. And we know some of the measures that have been proposed or enforced by the Ministry of Health or by the government is partial or full lockdown and curfews, restriction of movement. We know the counties which are now referred to as disease infected zones, where people are not supposed to leave or supposed to come into. Of course, the issues of physical and social distancing, the putting on of masks, and also requesting the general population to work from home. And actually, we have seen counties like Isiolo and others requesting the non-essential workers to work from home because of the pandemic. And also we have experienced, of course, closing of worship centers, learning institutions, hotels and restaurants, and banning of political and other gatherings. And again, quarantines and isolations. And so this is some of the things that we have experienced in Kenya. And this has led to some observations. One of the observation or one of the experiences that we have seen with women and girls, including adolescents, is lack of access to essential commodities or items relating to management of menstrual hygiene. Again, we have no information because most of these, some of the girls and even women, of course, they get information from social networks, including information on how to manage menstruation well, information on how to, what materials or what menstrual hygiene solutions to use, which ones are best, how to dispose them. So this information is no longer there. Of course, because of the lockdowns, we also have reduced privacy at household level, and also based on the number of people living in a particular household, you find that there's no privacy for adolescent girls and even women to change menstrual hygiene solutions. Another problem is economic strain because we know most of the livelihoods have been affected by the pandemic. And so affordability of menstrual hygiene products is a problem. And also there is heightened stress and there is a lot of fear, not only among adolescent girls, women, but every other person is fearing the fear of the unknown, the fear of the pandemic. And this one, there is information that it has affected some sexual hormones, which are responsible for menstrual hygiene or for menstruation. So you find that some girls and women experience heavy flows, others they experience painful menstrual hygiene or periods because of stress and fear. Next. Next. So these are some of the primary impacts of the pandemic on menstruation. Of course, we know menstrual period is influenced by what we eat, is influenced by how many hours we sleep and how much we exercise. And this has been affected by the response mechanisms towards the pandemic because people are not able to eat what they would have eaten in normal situations. And of course, because of anxiety, fear, and stress, some of the people's sleep patterns have been affected. And of course, also issues to do with exercising because of the call to stay at home. Again, due to physical distancing, some people are experiencing a dramatic change in their usual routine. As a result, some people have been reported, women have been reported to have missed periods, others experience spotting and also heavier flows than usual. And again, the government, though the government has given commodities to support the pandemic, menstrual hygiene solutions is not one of the essential items that the Ministry of Health has given to manage menstruation among adolescent girls and also women. The economic stress and lack of sustainable income has reduced the accessibility to menstrual management products. And again, there are some health workers who have reported an experience of having to take contraceptives. You know, the PPEs that health workers use. This might not be applicable to adolescents, but it is a problem which is affecting women. And of course, we know after the president signed the Basic Education Amendment Act in 2017, it is a requirement that girls get sanitary products or menstrual hygiene solutions from their schools. But now we had a period when schools were closed. And because they were closed, it means that the girls who usually accessed these menstrual hygiene products in schools could not access. Now, there are also secondary impacts of COVID-19, and one of them is lack of information. COVID-19 information has excluded the management of periods as key to create awareness on how to manage periods. This information is not there among the messages that we are giving for control and prevention of COVID-19. There's no information on how to manage menstrual hygiene. And again, we have people with disabilities and vulnerable persons, including adolescents, who have been provided with food by the government and provided with money to cushion them against the effects or the impact of the pandemic. But menstrual hygiene products have not been factored in this kind of support. Again, we know we have several menstrual hygiene management products. Some are disposables, others are reusables. But the production of the same has been hampered because some of the companies who have been initially producing menstrual hygiene solutions now have opted to move to where there is the demand, and they have been producing items like PPEs and others. And again, we know because of restrictions of movement, some of the materials that are used for manufacturing menstrual hygiene products cannot now be able to, we cannot access them. We are not able to access them as a country, and also some counties are not able to access these commodities because of restrictions of movement. Again, because of course, because of income and because of mobility restrictions, women, if the breadwinner was working in a certain place and they have been locked down in another county, then it means there are no resources to purchase these menstrual hygiene products. And as a result of this, like the adolescent girls, they must move to something. There cannot be avoided. This leads to negative coping mechanisms. Some of them is using unsafe menstrual materials, which might lead to reproductive health problems, or some of them choose to go for transactional sex. And so that's why that's why we have seen an increase in teenage pregnancy and also infection of HIV, AIDS, and other STIs. Again, there has been disruption in provision of basic social services, such as education and primary health care, through which adolescents access MHH-related social support skills and knowledge, as well as menstrual hygiene supplies. And of course, the hardware to do with management of menstruation has also not been spared because issues to do with water. We know we need a lot of water for hand washing, and the same water we need to manage menstruation hygienically. And so this also has been hampered, both at healthcare facilities, also in schools, and also in quarantine centers and isolation places. Some of these facilities have not been provided to manage for the people who have been isolated or under quarantine to manage their menstruation adequately. Next. So these are some of our recommendations. I'm not very sure the people that I'm talking to, but of course, this is an opportunity for us to be able to sell out our ideas as a hygiene sector. We propose or recommend that menstrual hygiene products should be included among the essential healthcare items or commodities in material procurement, especially this time of the pandemic. Again, menstruating healthcare workers need enough quantities of menstrual hygiene products. which are compatible with their needs to wear personal PPEs for many hours without breaks. And again, we need not to leave anyone behind. We need to engage persons with disabilities, including adolescent girls and the vulnerable adolescent girls, to better understand their unmet menstrual needs. Again, ensure that the supply of menstrual hygiene solutions in our schools is sustainable. And also, we should ensure that there is good messages or messaging to do with the correct way of addressing menstrual hygiene issues. And again, girls and women should be encouraged to keep in touch with their social support networks, even during this time of the pandemic, so that they can be assisted with ideas on how best they can menstruate with dignity. Again, a psychosocial support and counseling mechanism should be established to support girls and women. And also, it's very important to include boys and men in menstrual health and hygiene discourse, because, of course, we have known some of the people that have been perpetrating stigma and shaming of the girls who are menstruating are boys or they are men. So these men, these boys, we know tomorrow they'll be the husbands, they'll be fathers. So they should understand what is required for women and girls to menstruate with dignity right from their early ages. Healthcare facilities should have menstrual hygiene management, friendly facilities, including all the items, all the commodities that are required to ensure that they're able to change and wash their hands with soap, and they should also be able to access disposal mechanisms or disposal facilities for the disposable menstrual hygiene products. Again, it is important also to think about quarantine centers and healthcare facilities and ensure that we have the products and we have also the hardware or the infrastructure that is required for the people using the quarantines and the isolation centers to menstruate with dignity. And again, African governments or the Kenyan government should promote accessibility of products, and this should be available at all times. And we recommend that we have variety of menstrual hygiene solutions so that girls and women can be able to choose from an informed point of view. Next. Thank you. So we have been conducting trainings on menstrual hygiene management, and this picture shows one of such trainings. I think of importance is the young man wearing a brown coat. This is one of our national menstrual hygiene management champions, which means we have incorporated boys and men as much as possible into the menstrual hygiene management discourse. It is important to also note that we have developed a menstrual hygiene policy and strategy, and we have also worked on several other guidelines and standards, mostly to be used in schools. We have menstrual hygiene management teacher's handbook to be used in primary school. We also have a hygiene promotion book also to be used in primary school. And we are also developing training materials for menstrual hygiene management. And with these few remarks, I think I would like to hand over to Professor Nduati. Thank you very much.
Thank you so much, Janet Mule. Thank you very much for that presentation. It's pretty sobering that there are many young women and women who don't have access to menstrual hygiene products, and I think sobering that as we were on the forefront looking for PPEs for health workers. This is one item that didn't come onto the radar screen. So thank you very much for educating us on this matter. Now I want to at this point hand over the chair of this presentation to my colleague, Dr. Lucy Kabare, who will introduce the next three speakers. Remember that at the end of the third presentation by Josephine Omondi, the session will be open for question and answers and even just reflections from people who are attending this seminar. Thank you.
Thank you so much, Professor Nduati. I hope I'm audible.
Yes, you are, loud and clear.
Thank you. Now, the next presenter we have to save on time is Professor Peter Geshenge, who I have known for many years. His topic will be family planning and ROI among adolescents and the youth. Professor Geshenge, I don't want to spend so much time on introduction. Please feel welcome.
Thank you, Dr. Kabare, and thank you, organizers, for this meeting. I think Dr. Kihara, if somebody could upload my slides.
They should be coming from Kinudhia's end.
Okay, thank you. So as Dr. Kinudhia is uploading the slides, it's really a privilege to be in this meeting and to share some of the experiences, personal as well as from the project perspective, performance monitoring for action and for accountability. So I'll be sharing slides from the project as well as standardized slides from other sources for us to understand and to appreciate family planning as a return on investment, focusing on adolescent and young people. Dr. Kinudhia, we are waiting.
Yeah, Dr. Geshenge, one of our machines is hanging. We want to try a different one.
Okay.
Yes.
That's fine. If okay, so there we are. So I think, thank you, Dr. Kinudhia. So I'll share with you my synthesis on family planning as a return on investment among adolescent and young people. I'm currently the Deputy Vice Chancellor in charge of academic research and extension at the Technical University of Mombasa. So that CARA scheme is a CARA scheme for the university where I work. Next slide. So if you look at 15 to 19-year-old, and my apologies if I spend all my time talking about adolescence, because adolescence is a very important period of time. And I think we have had many important elements from HIV/AIDS, from menstrual hygiene, and others. That truly speaking, this is a very important period in one's transition from childhood to adulthood. It has long-lasting impact in terms of things which happen at that period of time. And it is really important to note that there are things we can intervene at this level. And one of them is family planning. So if you look at adolescents 15 to 19, we note that nearly 40% of them by the year 2014 were actually sexually active. PMA, we found the same, about 40%. So over a period of about 7 or so years, we have not seen a lot of changes in terms of ever sexual experience. But also notable is that by 2014, about 18% had begun childbearing, or they were already mothers at that time. But what we find reassuringly is that about 14% in 2020 of the adolescents were either parents or had begun childbearing at the time of the survey. So clearly at those two time points, we see seem to be seeing some benefit. If you look at modern contraceptive use among adolescents, it was about 9% in 2014 and is about 14% in 2020. So clearly, I think we are seeing some movement, and I think this is a result of the investment which have been done. We have noted that the unmet need for family planning in 2014 was about 23%. KDHS is a Kenya Demographic and Health Survey. The year it was conducted was 2014. We are hoping that this year or sometimes next year we'll have another DHS. So why is it important for us to appreciate these facts? We know there are risks of unintended pregnancy among adolescent and young people. And if you look at for the 15 to 19-year-olds, we see that nearly 40% of the pregnancies were unplanned in 2014. PMA, we are noting about 75% of the pregnancies being unplanned. So unintended, unplanned pregnancies, we know the consequences of those pregnancies is unsafe abortion. And again, if you look at disability adjusted and derived lived, then we see significant problems associated with unsafe abortion among adolescent and young people. Next slide. So this is a population pyramid from the 2019 census. I think important for us is to appreciate, if you look at the proportion of children below 15, we have seen a decline from 43 to 39%. So that's why you see a little bit of tapering at the bottom. And we shall be revisiting this slide, looking at demographic dividend and what it means for us as a country. So really, we are bottom heavy with a lot of young people, with very few people. And again, if you look at the bracket where people are supposed to be working, 19, maybe to about 45 and 55, we are very narrow population there. Next slide. So this is an important slide, data which is from performance monitoring for action and accountability, starting all the way from 2014. And we see that there are changes in terms of use of contraceptives among all women. We have moved from about 40% to about 46%. If you look at married women, the green line, we have moved from about 56% to about 61%. And unmarried but sexually active, then in between there. It's important to reflect on the gains made over time, because this truly is a reflection of the investments in family planning in this country, which is moving us towards the target which we have set as a country for contraceptive use. Now, in the background of this achievement, it is important, next slide, to appreciate that if you look at the young people, particularly 15 to 19, they are left behind when you look at all the indicators. If you look at all the adolescent girls, 15 to 19 years, about 14% were using a method of family planning, a modern method. But if you look at 20 to 24 years, the number shift moves from 14 to 51%. If you look at 25 plus, is about 58%. So clearly the adolescent are left behind when you look at those interventions. What about those who are married? About 48% were using a method compared to 58 or 62%. What about those who are sexually active? Again, you see about 47% were using a method compared to 63 and 66%. So really, this is an important matter to look at. And again, if you look at the sexual needs, reproductive health needs of young people, we need to be able to recognize that in the mix of things, unless we specifically seek out and intervene for them, they'll be left out, as we can see in this particular slide. We move on to the next slide. So the question then I was asked to address is return on investment. And this is an important question, particularly when you look at advocates, and all of us, one way or another, needs to be advocates, because we have many times we are privileged to have the data. But there are 5 models which are commonly used. And this important to note is that these estimates are not interchangeable. And I will share with you a little bit more details regarding these models. But more important is if you look at the gains from family planning, it's across the continuum of life. And so if you're looking at a model which measures and monetizes all the savings accrued because you have invested in family planning, then there's no single model which is able to do that. And therefore the need to recognize the different models and the different estimates you can get, bearing in mind that these estimates are not interchangeable. But what we know as obstetrician and gynecologists and many of us in the space of public health, that if you look at family planning, their benefits are across the continuum of life. You have improved infant and maternal health, you have improved educational outcomes, you have greater workforce participation, you have societal benefits of strong economic growth, and certainly you can see that by investing in family planning, you have less environmental impact. And how? Because sometimes when you look at these things, it almost sounds like a stretch of one's imagination. But if you look at areas, populations which are highly concentrated, the impact on the environment is enormous, because people must find firewood or fuel and other things required, and the degradation which happens as a result of overexploitation of that environment because of pressure from numbers is important. So you can see that not one model is going to be really one which then gives all the estimates because of this thing. But I think if you meet anybody on the street, any policymaker, any decision maker, I think the words from your mouth should be family planning remains one of the best buys in terms of investment for both at individual level, community level, at the national level. Next. And so if you look at the models, what are these models? The Gutermark Institute has a model called Adding It Up. And this model was born to inform policymakers and advocates and funders of the benefits and cost of contraception and maternal and newborn health. And so if you look at the short-term element, it is from this model, we can see that every additional $1 above your current level of investment in meeting the unmet need for contraceptives saves about $2.2 in pregnancy-related care. This is antenatal care, delivery care, and any other complication which may arise. So clearly, addressing unmet need for contraception reduces the cost of maternal and newborn health services by reducing the number of unintended pregnancies. And that is very important. So clearly, if you're looking at short-term benefit, it's very clear that we do have. Intermediate benefit, this model has not been evaluated for that, and so is long-term benefits. What's the other model? And this was the Millennium Development Goals. The purpose was to advocate for family planning in a multi-sectoral environment. And here, multi-sectoral environment was looking at measuring savings in meeting the MDG targets, resulting from meeting unmet need for family planning. And what we see across 16 countries for which the model was applied, that every dollar invested in meeting the unmet need for contraceptives saved anywhere between 2 and 6 in cost of achieving MDG targets. We know we did not achieve the MDG target, but again, that still gave us a reason to believe that yes, intervention in family planning, and here specifically looking at met need, is of benefit. Next slide. And so this is another 3 models I'm going to share here. And so many of us are aware about the Copenhagen Consensus, which looked at to compare cost effectiveness of different development interventions. And key to this consensus is family planning is among the most cost-effective development interventions. Long-term benefits, not yet included. So for every dollar invested in meeting the unmet need of contraceptive, the long-term yield was about 120 in accrued annual benefit, 30 to 50 being from reduced infant and maternal mortality, 6 to 100% from long-term benefit from economic growth. So every $1, we can see the accrued benefit. The family planning sustainable development goals. From MDGs, we came to SDGs. And again, this is an advocacy tool to help achieve sustainable development goals. Intermediate evaluation has been done for this model, which shows improvement in socioeconomic status along with investment in family planning, which maximizes progress towards demographic dividends and sustainable development goals. And I'll be sharing something on demographic dividends later on. And the last one, which then leads me to the next couple of slides, is the demographic dividend, which is to generate support for family planning and reduce health and reproductive health investment in high-level policymakers outside the health sector. All of us in the health sector, we understand clearly reduction in unmet need and so forth, but people who are not in our field may not necessarily understand that, and that's why this measure or model was developed, and which clearly shows that reduced fertility leads to reduced maternal and child mortality and improved maternal and child health outcomes. If this happens, you have increased labor market productivity, which results in increased GDP per capita. Now, very, very important, because we see that, and this slide is particularly important. If you look at 2010, we had about $907 spent. At the base of 2050, we are projecting 2050, if nothing has changed, you'll be spending about $896. But if you intervened in the economic matters only, so you have improved the economic well-being, you're able then to generate wealth, then you get to about 6,693. If you combined economic interventions with education interventions, then you get to about 8,748. This is gross domestic product. What if you combine the three? Economic environment has been improved, education status of our people have been improved, and you have added family planning. You can see we jump from 8748 to 11288. And that component is what has been described as demographic dividend. It is the same scenario in 2050. You can see the GDP is about less than 1,000. But if you have economic stimulus, you get to about nearly 7,000. Economic stimulus plus education, you get to another about nearly 9,000. And we see clearly, if you combine education interventions, economic interventions, and family planning, you're talking about GDP of about more than 11,000. So this is the power of that combination. Next. And so this is a transformation we will see in Kenya, and this demographic dividend has been done for Kenya as one of the model countries. We see that to the left, 2050 base scenario, no interventions have happened, population pyramid remains bottom heavy. If the interventions have come into place, we see in the scenario to the right that we have a narrow young population. We have a little bit of a bulge between 15 to 19 and about 55 to 59, the green part. And all of us appreciate it is a green part which is more productive. It is a green part which is going to generate wealth. It's a green part which has less dependence, and therefore they can be able to invest more in their children. And of course, they will have money to invest in development of the nation. And therefore, the value of us to think about demographic dividend as we look at family planning as an intervention to spur development and address other challenges in terms of health. Next. So Kenya as a country, we have committed ourselves, and indeed we have an implementation plan for the ICPD 25 plus, where we know and have just demonstrated that indeed access and use of contraception by adolescent and young people is one of the important pillars to enhance country demographic dividend and progress economically and improve livelihoods. So in Kenya, the commitment is to employ innovation and technology to ensure adolescents and youth and attain the highest possible standard of health. And so to achieve that, what is being done? What actions are being done? And this is being led by UNFPA and other government ministries and agencies. establishment of consistency innovation hubs to facilitate access to life skills education, entrepreneurship training, sexual reproductive health education. To develop applications for youth-friendly sexual reproductive health information, which they can be able to access and use, integrate and nurture adolescent and young sexual reproductive health related social enterprises and innovations in SRH programming at all levels. And I think the previous presenter, when you are talking about menstrual hygiene products and others, this could be one area where the youth are very resourceful. We're looking to establish, operationalize multi-sectoral working groups. This is health, the youth themselves, education, to harmonize and harmonization of policies. We have seen 3 key indicators: economic empowerment, education empowerment, family planning. Then you spur growth in a very dramatic way. We need to finalize and implement strategic Ministry of Health policies like the RH policy, commodity security strategy, and others. And we also need to continue to provide education to create demand for sexual and reproductive health intervention at community level. And my apologies is something little hidden, which we were not able to see. But that is to advocate for integration of comprehensive sexual reproductive health services and universal health care packages. So clearly the country is committing itself to do these things, and the action being planned to ensure that adolescent and young people then will be taken care of. Next. So we have just seen that, yes, the commitment is there, and we are hoping to get to about 70% in terms of modern contraceptive use. There are counties which already have achieved that, but I think looking at the trajectory, but I would like to pause here and say, yes, as you get towards your target, the rate of growth of family planning use becomes very slow. And therefore, if you look at the S-curve as a country, we need to appreciate that, yes, we have been doing 1 to 1.5% per annum growth in family planning use. But as many counties get to the age of 60, then we expect a very slow growth. We know that there are plans to increase national and county government budget for family planning. We are also looking at eliminating commodity funding gap, and these matters are being spearheaded by the government. So I was in a meeting recently where the government is planning to really be in charge of commodities for family planning in the very near future. We are hoping to improve a logistics system to reduce stockouts, which continue to be a challenge, and to make the products readily available for both men and women. Again, it is important to appreciate that family planning is not only for women. Next. So in conclusion, we have seen that there are different models which are being used to make strong case or prediction for investment for family planning. And it all depends on the choice of the model you use. Noting that, yes, there'll be a lot of explanation to give to policymakers, but depending on the choice of policymaker, then it can inform you the kind of model you need to be able to look at. For example, demographic dividend, you're looking for persons outside the health sector. It speaks to something they can understand easily. If you're looking at Copenhagen Consensus, then you're really monetizing the benefits from these investments. If you look at the challenges I mentioned earlier for adolescent and young people, it is even more compelling to ensure that these persons are reached with family planning methods to be able to benefit from the true benefits of family planning. And therefore, it remains important for all of us to communicate clearly and correctly so that we can reduce confusion. Because you may have been in settings where people are not entirely sure demographic dividend makes sense. Copenhagen Consensus is some people in Copenhagen who are doing their own business. It has nothing to do with us. But indeed, all these things are important. We will continue to seek opportunities for improvement and expansion of efforts to capture the full range of family planning benefits. So for me, from academia, this is a challenge for us to be able to say, other than these models which exist, which other models can we come up with, which maybe are able to capture beyond the monetized part, as we have seen that indeed family planning has lifelong interventions. And with that, I wish to thank you for the opportunity and for listening to me. Thank you, and back to Dr. Kabare, the chair.
Thank you so much, Professor Geshenge, for that presentation. Indeed, it is enlightening. It's also important to have noted that you're putting some economic value in family planning, which is critically needed even for the adolescents. Thank you so much. Our next presentation will be by Dr. Simon Joguna on mental health and well-being. I have listened to Dr. Simon Joguna, though he may not be aware on several occasions, and we wish to invite him to please give his presentation. Welcome, Dr. Joguna.
We have Dr. Omondi continue as we find out what has happened to Dr. Joguna.
Oh, okay. I think we have all heard what Dr. Kenodia is proposing, that we move to the next presenter, who is Dr. Josephine Omondi, and his topic is on drug and substance abuse. I know Dr. Josephine Omondi for a long time, and one of the things I have really appreciated is the way he handles children and mental health. Welcome, Dr. Josephine Omondi.
Good afternoon. I hope you're able to hear me. Can you hear me? Can you hear me?
Yes, Josephine, we can.
Yes, okay. Thank you very much. Now, let's go to the next slide. Substance use is a big problem in this country and actually worldwide. And addressing it within a short time is very difficult. However, I try to just summarize what the most important things so that I can share with you. So we look at some of the terms that we use in substance use. We look at some of the causes and risk factors, then characteristics of a substance user, and then the assessment, what is required, and then the interventions and some of the protective factors. Let's move to the next slide, please. Now, in substance use among the youth and even adults, when we talk about substance use, it really refers to the maladaptive pattern of usage of substances, and the substances, the psychoactive substances such as alcohol, marijuana, cocaine, and etc., which lead to clinically significant impairment or distress. And this is usually manifested by several of the symptoms within the period of 12 months. And what are these symptoms? One is recurrent substance use in situations that cause physical danger to the user. And this is what sometimes we see in our outpatient areas, where patients are admitted with the effects of the substance use, and they're admitted and then they're discharged, but they continue using it despite being told the danger. Then there are recurrent substance use in the face of obvious impairment in school or work situation. Now, in our youth clinic in KNH, we see a lot of these young people who are using substances, and they are sent to us from schools, from the institutions, and sometimes it's the parents who bring them. Then there's the recurrent use despite resulting legal problems. And here we see among the youths who have already finished school, some are in school, but others have finished school and they are working, or they are doing some involved in economic activities, but then they engage in some illegal activities, and then they get apprehended by the police and presented to the courts. But despite that, they still go back and continue the same. Then there's recurrent substance use, regardless of the social or interpersonal problems. Here we see them within families. We also see them with interpersonal relationship where they come because they were beaten up or they were involved in some violent activity or in some, again, illegal activities. Then we find them here. They come to us and we are able to see them. So it is good to note that their physical well-being is in danger, their emotional well-being is in danger, their socio-occupational functioning is also in danger. Next slide, please. The other terms, as most of you, some of the clinicians that are in this presentation, when you're in the wards, you hear a patient has been admitted because was intoxicated, but sometimes you're not told which intoxication. Many a times it's related to alcohol or it is bangi. And there are three most common substances that we see: alcohol, cannabis, and tobacco. It is very rare that you'll find a patient admitted or you see a patient with using only one substance. Many times it's a combination of substances. So substance intoxication refers to the development of reversible substance-specific syndrome caused by the use of a particular substance. So you'll have a patient admitted with alcohol intoxication or cannabis intoxication or heroin intoxication, such like. But as I said, the majority of many times it is the three drugs, which are usually the gateway drugs: alcohol, cannabis, and tobacco. Then there's the substance withdrawal. And this refers to a substance-specific syndrome, which is caused by the cessation or reduction in prolonged substance use, and which causes clinically significant distress or impairs social occupational functioning. Those who are working in the offices or in the different institutions, you'll realize that some of these patients, when they come to work in the morning, they are already having withdrawal syndromes. And within a short time, they get out to go and look for the substance so that they can take it in and be able to work. Otherwise, it will not be possible for them to work. So if they are not able to get the substance, then you'll find that they'll have to be admitted so that they can be contained. Next slide, please. Now, what are the causes and the risk factors, especially among the adolescents and the youth? Parental modeling of substance use is a big problem in our country and also worldwide. When children are brought by their parents or caregivers to our youth clinic or to the different areas that we see these patients, many times we insist that the parents are availed. And sometimes as you ask for the information, you realize that one of the parents or both of them have been taking the substance, and therefore they were modeling for the child. The family conflicts within vulnerable youths who have no problem-solving skills. That is another thing that we have seen among our youth and is documented. Family conflicts, especially in this era that we are having lots of economic difficulties, lots of interpersonal relationship difficulties, marital difficulties. So all that is leading to conflicts, including school underachievement. And all this can push an adolescent and a youth who is not able to manage their problems in an amicable manner, be pushed to take substances. Then lack of parental supervision and individual stressful life events. This is something that has been emphasized in any institution. When we meet parents of this, when we go for parents' days and in the clinics where children are being evaluated, there is always emphasis that parents need to be available. But with our economic situations, parents are not available. They are both working, maybe they're working very far, and children are left on their own. The youth and also the adolescents are left on their own, especially now that they have a very long holiday, and the time that we had lockdown for almost 6 months, that was the most difficult time. And so that the lack, parents realize that the value of the teachers. And so the lack of parental supervision is a key factor in contributing to substance use. Then peer pressure as the children move to adolescence and then finally the youths and then adulthood, they go through the third phase of what we call separation individuation. And this third phase of separation individuation, they try to look for identity. Now, if they did not get identity from the family, they look for other people to identify with. And that's where you find that the peer pressure is so strong that they are forced to, they find themselves into substance use. The other factor is use of substance use as an escape in the presence of a comorbidity. Now, as we see these young people in our youth clinics, we realize that substance use does not just exist on its own. Many a times we find during the evaluation, we realize that the youths have comorbidities with other mental illnesses. Majority of the times are the mood disorders in form of depression or bipolar illness or cyclothymia, or sometimes there's existence of a medical condition which the patient is not able to deal with, and so they escape into substance use. Then there's the availability in terms of affordability and access. Now, some parents, because they are not available, they try to cover up for their unavailability by giving a lot of money to the youths, and the youths also demand money. And once they have access to that money, then they are able to look for drugs and they will get them. By the way, in any estate within Nairobi or within the cities and towns, you'll find the drugs are just a few meters away from your house. And so accessing them is very easy. If the youth is not supervised, the youth is not very well connected with the parent, and the youth has the available funds to afford to buy the substances. Then curiosity. Again, curiosity is one thing. Every human being is curious, and they would want to know what is going on. How does this feel? So some of them get very curious and they want to test and see how it, what actually happens. And so curiosity and experimentation all go together. They'll be curious, they access the drug, and then they start experimenting. In the process, they get hooked into the substances. Then we've also seen in our circumstance in KNH that when children join boarding schools or a new school, there's this big demon that we call bullying. And the bullying has evolved to a point where it is used in a passive aggressive manner. So when the children join, when the youths and the adolescents join schools, there's youths who have been there earlier, they will bully them by asking them to carry for them, to keep for them those substances, or even to use. And if they don't use, then there are consequences to that. So then this has been used as a bullying agent, and it is important that we note that, because some of the children from as early as 8 years, 10 years, they start using this substance because somebody introduced to them in form of bullying, or even from 1 and 2, and subsequently they use the substance. By the time they're finishing high school, they are a wreck because of what happened to them at a very early age. Next slide, please. Now, what are the characteristics of a substance user? These are not, they are non-specific. They are usually non-specific, or most of the users tend to use multiple substances. So you'll find there are so many symptoms that you cannot separate. You cannot say that this is because of alcohol, or this is because of cannabis, or it's because of tobacco. But there are certain behaviors that we look for and are pointers towards substance use. But you cannot just use that behavior alone. there must be some corroborative information to confirm that this person is actually using the substance. Some of the characteristic symptoms are self-isolation. The youths and the adolescents, because they are separating from parents, they are trying to look for their own identity. They are trying to understand themselves. In the process, you'll find that many times they are locked in their rooms or isolated somewhere. And in the process, some of them get into substance use, spending too much time with friends. Like you are told that, oh, your son left the house at 10 and is not yet back at 8 p.m. Where did he go? He was spending time with his friends. What were they doing? You don't know. So spending too much time away and with no clear, meaningful activity is a pointer. Then habits of sustaining the use, such as stealing money or picking some household items and selling them, that is a pointer, or even selling their clothes or giving away their clothes, that's a pointer towards substance use. Having red injected eyes, and many of the substances do that, they do that, and so it's good to be observant. But some youths will time when their parents are away, they'll come in and out and they'll stay in their rooms, or they'll say they're not hungry, so they'll not participate in the family togetherness when they're having lunch or supper. So, and that will be a habit that is continuous. But then when you realize that this youth is actually taking substances because they are avoiding parents to see their injected eyes. Then change of appetite. Some don't eat a lot, but majority of them do eat too much. Of course, this is encompassed with their growing age, but also with this habit of engaging in substance use. Loss of emotional control. There are times that we've had youths brought to our center, and the report is always that they are aggressive, they are violent, they have beaten their sister or their brother, they have fought in school, they have been involved in some gangs. So that is a pointer. They lose emotional control, they get temper outbursts, then interference with sleep, and also the appetite that I've talked about. Then deterioration of personal hygiene. This is a common finding amongst our youths who come to the center. And the first thing is, as they come to see us, you look at how they present themselves, their dressing, and you realize that the dressing is very shabby or they're very dirty. And so you wonder, is this substance use, or is it a mental illness, or it is just carelessness? So again, that is a pointer towards substance use because they have no time to take care of their personal hygiene. Then sudden change of habits, like chewing gum all the time for a youth who was never doing this, or use of colognes so that they can mask the smell. They can also mask the, the sense of the substance that they had used. So these are some of the characteristics that we see. But again, it is very difficult to tell. So you cannot conclude just with this information. So you need much more to be able to make a diagnosis and intervene. The next slide, please. So how do you intervene? This involves a careful interview of the caregiver of the parent or the parent and the patient. And that's why in our youth center, we insist that if a youth is brought to the center, there has to be an accompanying caregiver or a parent. Some of them, of course, are naughty. They end up bringing their friends, but the friends will not help much. And we can tell that this is not their parent. So we still insist that they bring their caregiver or parent. Through observation in mental status examination, and we check for the telltale signs. Telltale signs are, of course, how they look in terms of being kempt, their attitude towards hospital and being asked questions. Some are actually very aggressive verbally, and when you ask them questions, they actually challenge you. Why are you asking me this question? It's not important. Or they even tell you that outrightly that they have no problem and they don't see why they were brought to the center. So those are some of the signs that you need to look at, observations. And of course, in the mental state examination, there are other areas that we look at. We look at their mood. We also check their thinking and also their perception and their cognitive understanding of their problem and whether they think it's a problem or not. And then we go further to get corroborative information, which is provided by a reliable source. And the reliable source can be a brother, can be a sister, can be a parent, can be a friend, can be the teacher, or even the priest and any other. After that, of course, you realize that you are almost sure that this person is using substance. If they are not willing to volunteer information, then we go further to do the laboratory checks. And the laboratory checks requires toxicology of the urine or blood. But blood toxicology is quite expensive. And so the cheaper one is the urine toxicology, which right now KNH is doing it. They never used to do it. So we used to send our patients elsewhere. And I believe other government institutions and private institutions should be able to do this. There are simple tests that can be done that can help us to be able to know whether this person is actually using the substance. Majority of the substances take a few weeks to about a month in the system, so it is possible to detect whether the patient had used them within a month or stopped using them within a month. Next slide. What is the intervention? And this is where many of us sometimes have no idea, and parents also have no idea. They think that when they bring the youth to the center, they can just be counseled and all will be well. But that is not the case. The intervention is a process, and it is a complex process. Now, the first thing is, if one has evaluated the patient and realizes that this is just a simple experimenter who is just using the substance, that can still be salvaged. So simple regular counseling, especially for the mildless use, is possible to salvage, and if they are self-motivated. But majority of the times, the youth has used this drug for a long time. And so it is not possible to just cancel and assume that all will be well. So hospital admission is key for the physical detoxification and further exploration of comorbidities. Remember, majority of the substance users, whether it is a youth or an adult, and here we are talking to the range of 80 to 90% of the substance users do have underlying mental illness. And the underlying mental illness, you can start from attention deficit hyperactivity disorder, from borderline personality disorder, and then the mood disorders, the depression and the manic episode. So admitting them will give an opportunity to be able to explore what the underlying mental illness so that they can be managed. Then the admission gives an opportunity to dry up the patient so that they have no access to the substance, and then they can be able to think clearly. And it is only after that that the patient can now be prepared for the psychological detoxification. The physical detoxification as an inpatient in the hospital takes a period of 10 days to 14 days. Thereafter, then admission to a rehabilitation center for psychological detoxification. This is where it takes a period of 3 months to up to 9 months. Some take 3 months, others take 6 months, others take 9 months. But despite this, the literature states that if a patient has undergone psychological detoxification for the first time, there's a high chance that the person is likely to relapse. And that's why we talk about follow-up. Once a drug addict is always a drug addict. And so we emphasize on follow-up, because after psychological detoxification, there's likely to be a relapse. And even the second psychological detoxification, there's likely to be another relapse until you go to the fourth time. And once you do the four rehabilitations, then you are likely to have wellness. But otherwise, you'll always get relapses. And this is where we have problems, where institutions will lay out people because there's always that notion that this person has refused to recover, but it is just because the complexity of the problem of addiction. Then of course the follow-up, and the follow-up, there has to be commitment. If there's no commitment, there is nothing you can do. And this is what makes it very difficult, because the drugs are easily available and the youths are looking for them, and the peddlers are ready at any given time. And the people who are peddling, we have no control. We can only control those who come to us. But the ones who are peddling, there's nobody who is following them. So it becomes a very difficult thing to manage, although we try to the best of our ability. The next slide. Then what are the protective factors? The protective factors are those that mitigate substance use. And these are stable family life. Stable family life has never gone wrong. And we all yearn to have stable families. Now, if there are conflicts, as we had already seen earlier, those are some of the risk factors that send these young people to substance use. And remember, an older youth, or even a mid 20-something-year-old youth, is by the time you realize they are using substances, they are not starting at that time. This is something that they had started earlier on, but nobody picked it. Then they got a lot of freedom and they started using it. So many times when you ask, they started very, very early, and many times from high school, and a few of them from senior primary school. Strong parent-child relationship is a good protective factor, and we have seen it. Even those who try to experiment, when they have a good parent-child relationship, you realize they get out of the problem very fast and they remain well. Then consistent parental supervision. Again, consistent parental supervision, and here it's all related to parenting. Who are the parents? What are they doing? Are they talking to this child? What is their relationship? These are the things that we look for, so that we find out if we can get any protective factor, then we emphasize on that so that we can keep the adolescent away from the substance use. Then investment in academic achievement. And we have seen it. Those who are doing very well, or those who are performing, they're stable, you'll find that they keep away from substances. But of course, there are a few who are not able, who are doing very well, but then they get into substance use because of other reasons. Peer group that models pro-social family and school behavior. This where parents come and say, this youth has bad friends. And when I talk to him to keep away from the bad friends, because they are influencing him negatively, this is what it means. When you have youths who are good, who are pro-social, who emphasize on good behavior, you'll find that they'll attract this youth who is engaged in substance use and is likely to keep away. So if we can emphasize on these factors, then we are likely to keep these youths away from the substance use. But there are those other factors, the legal factors regarding substance use and the peddlers, that is beyond us, and now it requires the policymakers so that we can be able to get them, and they are apprehended so that they can also, be punished for peddling substances. So I think that is all. Thank you very much for listening to me, and I will be happy to answer the questions. Thank you.
Thank you so much, Dr. Thank you so much, Dr. Josephine Omondi. We are grateful for that wonderful presentation. At least for today, I got to understand that you can continue taking somebody for rehabilitation even up to 4 times or maybe beyond. We used to think if you take once or twice, that is the end, and this person simply cannot recover. Thank you so much. We want to go back to the presentation by Dr. Joguna. I'm made aware that he is now back with us. Dr. Joguna, you can take up. We had invited you before.
Yeah, so thank you, Lucy, for having me and for this opportunity to present in this symposium. I was there, but I was there by a different name, Dr. Kahonge, which is still my name. So that's why Dr. Kinodia was getting confused whether I'm around or not. So I'm supposed to discuss about adolescent mental health. And as I discuss these subjects, I would like us to look at 4 questions. And this is what is mental health, especially for adolescents? Why mental health in adolescents? And then try to see how does the whole mental health and well-being spectrum manifest in adolescents, and what can be done at the various levels to address the issues of mental health. Next slide. So I'll start by a very simple definition that there is no health without mental health, because basically when we talk about health, it's the mere triad of physical, mental, and social well-being, and not the mere absence of infirmity. And further to this, very interesting to understand what is mental health, which means mental health is not the mental illness. It's a big continuum where we look at from the mental well-being to addressing issues of mental illness, is when individuals have the ability to actualize their potential. And this is very key as you see as we move on this subject among adolescents. And also to work productively within the community and to cope with stresses of life. So that without more emphasis, it shows why it's so important to have mental health in the young people. They are able to actualize their potential, they are able to contribute to the society, and they are able to deal with day-to-day life stresses. And the next slide. So when we talk about mental health or psychological health, especially among the adolescents, we'll try to see how does it feel that these young people, when they're able to contribute to the society, they're able to address issues of stresses in life and work productively, how would they look like? And this mainly will manifest in terms of, their appearance, their behavior. It will manifest in their thinking, in their expressions, in terms of emotions, and in terms of thoughts. And basically, some of the elements you see in among young people is they feel good about themselves. Psychologically healthy young people will be able to interact with other people in a comfortable way. In the community they are living in, whether in school or at work, they will be able to cope with various tensions or be able to address any tense or other difficult situations in their life, and also meet the various demands of life. In terms of their thinking, they'll be able to address issues about hate, feeling of guilt. They'll have a forward positive outlook. They'll be able to enrich the life of others. That is, when they are working with other people, they will have a contribution. You may have seen people when you work with them, they may be quite difficult to be part of the team, and probably there could be issues about their psychological health. Their appearance, someone who smiles, they'll be well groomed, they'll value diversity, and they will enjoy the environment and also respect nature. So basically, that's the kind of an adolescent we are looking at when you say a psychologically healthy adolescent. It's that young man who is out there looking, that kind of a picture I've tried to paint. Next slide. And now comes the second question. Why mental health in adolescents? Why is it so important that this is a cohort in the life course that mental health is so crucial, more crucial than probably any other age cohort? One thing as we see adolescence is that stage people are moving from childhood to adulthood is a transitional period. And there are a lot of developments which happen around this stage, and mental health will be very crucial for someone to go through that transition. What has also been observed is that the onset of most of mental health conditions occur during adolescence. Most of the mental conditions, 50% of those conditions, their onset is by the age of 15 years. And 75% of most of mental health condition is by 25 years. So age is an element in terms of risk factor, if I put it in quotes, when you talk about mental illness. So most mental illness start at a young age. And so how we have the prognosis or how we prevent those onset of those mental conditions depends on what is happening at that transitional period. Again, very important is to understand that mental conditions and many other challenges can be prevented at this stage. When I mean the challenges, I'm looking at those conditions which affect the whole continuum of mental health and well-being, beyond that they may not have a classical diagnostic syndrome to be a mental conditions. What happened, it looks that some of the multifactorial issues associated with the causation of mental illness, there's a lot of things which happen around at this stage of life. So it seems there's a big interplay about these multiple factors, the genetics, the environment, and the biology of the physiology of the person at that stage. And so what happened around that time plays a big role in terms of prevention. And so scientifically, we can be able to have some interventions which could be very helpful in terms of prevention. One of these things is like the use of cannabis. The use of cannabis has been shown in terms of how much it may have effect, especially during adolescence, in the causation of some of or in the contribution to the onset of some of the mental health conditions, from bipolar, schizophrenia, and other mental health conditions. Then what has been shown is that suicide has a big impact within this age cohort. It's the leading cause of death for people for the young people between 15 to 29 years of age. These are young people. We expect them, they may not have other cause of mortality, like the common other general health conditions. And so one of the biggest cause of death at this stage is suicide. And so we actually have to put a lot of emphasis on issues of mental health at this age, because one of the really fatal complications at this age is suicide. Mental health conditions can be recognized and be treated. Why I'm saying this is because if we don't put our focus on mental health of young people, then we don't recognize these mental health conditions or the mental health challenges. And when we don't recognize them, we don't intervene in a timely way or in an appropriate way, and the prognosis is quite different if we have been able to recognize. So having this subject is very important at this stage. Caring peers, families, and community working together can work towards that prevention. So in a nutshell, that's some of the reasons why it's very important to address issues of mental health. Again, I've mentioned 3 key developments occurring at this stage, which also we really need to understand and put in consideration that mental health will be very crucial in transiting through these elements of development. The sexual development, especially the physical or psychosocial sexual development at this stage. Mental health will be a very key element for the young people to be able to go through that maturation in terms of their sexual and reproductive health. Then cognitive development. This is a stage when you're moving from childhood to adulthood, and gradually or progressively they will be transitioning from the way one thinks. They will have now the concept of formal operational stage, in where they are able to have abstract thinking and hypothetical reasoning. So they are able now to predict things, be able to get into systematic problem solving. And so as adults, how we address the young people is not as well when they are young. Their level of thinking now is going through a transition. It's also a stage where they go through the development of identity and also having relationships. And so there are many issues about their self-esteem, their body image are very critical at this stage in terms of forming identity and relationships. So these also tend to bring what we call the adolescence crisis. And so next slide, let's see some of these elements of adolescence crisis. So we are seeing a person going through a transition, and this transition comes with its own challenges, opportunities, and crises. And so mental health becomes very crucial because when someone is transiting from being dependent to developing some identity and independence, where they are moving from being at a parental influence to having a lot of peer influence within their life, where they look at things like style, fashion, sexuality, experimenting with drugs, sexual urges. It's very key that their mental health and well-being is very paramount. So in a nutshell, looking at some of these elements, this is why we are saying it's very important to make it a pertinent issue to address issues of adolescent mental health when you're addressing the health of the adolescents and the youth. Next slide. So having said that, looking like what is mental health or psychological health among young people and why is it important, I like to look at what are these challenges, how they manifest. Very importantly, when you talk about mental health, we normally talk about issues about feelings, thoughts, behavior, and relationships, and also the achievement, as we defined originally what is mental health. So anything moving a young people from that definition about actualizing your potentials, about coping with issues in life, about being productive, then we need to ask ourselves, what is happening in terms of the mental health of the adolescent? And so what we really need to look at in the manifestation is in their day-to-day life. Those who are in school, we tend to see how they are forming relationships, how they are doing their academic achievement, how are they dealing with stressful moment in the academic work, like during exams or during any other stressful moment in school. So things we need to look for is feelings, thoughts, behavior, relationships, and achievement. So low self-esteem, young people expressing manifestation of anxiety or being in low mood, issues of suicide and homicide or suicide homicide, getting into high risk behavior like unprotected sex, dangerous driving, substance use, disruptive behavior and unhealthy relationship, physical inactivity, a child who doesn't engage in a lot of physical activity, or a young person manifesting with a lot of physical illness, a lot of somatic complaints, which give them poor health, academic performance, dropping out of school, truancy, school refusal, an achieved milestone, and issues of sexual and reproductive health problems may also be pinpointing to some mental health issues. So these are things we really need to look at as the manifestation of mental health challenges. So don't expect to look for psychosis. Don't look for maniac episode in the young people. It will be too late by the time you're having a maniac episode or having severe depression. These signs, we need to look at them at a very early stages if we are to address issues of mental health. Simple things about the way young people or adolescents are going about their day-to-day life. Any changes, any significant changes, let's be on the watch. Let's see the next slide. So having said that, how this manifests is what can we do at the various levels as peers, as parents, as siblings, as a community, as various level, even at policy level. And I'll look at these issues by looking at individual level, what we tell the young people when we come across them is all of what can we do to help them is trying to build on their life skills, because this will help them negotiate in the various aspects of life. We need also to help them be able to build up relationships. Boys, girls relationships. Let's see how they can live together and form these relationships. Try to make sure we have adolescents and young people who are free of drug use, because we know the impact it has, and then the actual consequences of addiction, which is a severe disease, which may have a lifelong impact. Issues about healthy lifestyles. Let the young people exercise, have recreational activity. Terms of their nutrition and diet is very important. We address this. Personal hygiene, so that they can feel good when they are moving out there. And I think some of these things, as you mentioned, like menstrual hygiene, is very critical, especially for young girls and adolescent girls, because if it's not addressed, it may have a big impact on their mental health. At family level, as parents, as has been mentioned by my colleague, Dr. Josephine, help them develop the right skills to have critical thinking, problem solving, communications, be able to negotiate. These are things as parents or part of our parenting skills, we need to impart these life skills on our children so that they are out there, they're able to form healthy relationships, they're able to achieve their milestones. And that makes them feel good self-esteem, and get good mental health. And then relationships at family level, whether with siblings, with peers, with the parent, that's very important. And an environment which is caring and supporting. Ensuring that the environment is free of trauma, abuse, drug of abuse, any form of stress. And as we mentioned in school, there's the issue of the young people being harassed by their peers. Let's move to the next one. Also be able to provide them with accurate information and counseling on issues which they may require support. Importantly is to be able to pick early signs and symptoms of any mental health challenges or conditions. The next slide. Again, relationship very important, especially when they're out there with the peers, teachers, and others. Be able to provide amenities for recreation and social and entertainment amenities. It's very important because as we talk, like in our estate, every other piece of common or allowed for amenities has been clapped. We don't have children, playing football out there, playing other games, engaging in some social amenities, like they are provided with movies and other things, because now we are doing it more indoors, and they could be in dangers of now the technological advancement, where most of these education and social amenities are more within an environment where the child is not interacting with others. So they are more introverted as they get their education and social amenity, which may also have some demerits. As other communities, for the young people, they need to have some opportunities for employment, be able to express their creativity and innovation. There must be services which are adolescent friendly, and the healthcare workers must be able to be more friendly to the young people. They must be oriented to how they can provide services to the young people. So it's moving services from the traditional services to services which are more oriented towards the young people. And then also those who have mental health conditions or challenges, they should be able to live a normal life, and then they are assured to have management which will have some good prognostic results. So let's go to the next slide. At national levels, we need to look at our policies in terms of laws, legal framework that ensure that we create an environment which is very conducive for the young people, so that they can be able to attain or be able to actualize their potential. They have an environment which is enabling but not more stressing to the young people. They have an environment which is free of violence and discrimination, an environment where they're able to get the essential services they require, the reproductive services for the young people, whether the mental health services for the young people, and also they can have the education and be able to attain the highest of their abilities. Again, also policies which promote mental health and life skills, building of life skills among young people. So basically, that is what I see when I think of mental health and well-being of the young people. Why is it important for them? How does it invest? And what can we do at the various levels? So thank you for this opportunity, and I'll be available for any clarifications and questions.
Thank you so much, Dr. Joguna. Thank you for that wonderful presentation. We are indeed better than when we joined this particular symposium. Now, would rather go to the next stage, which involves discussion of questions and answers. Our time is really spent. We are behind schedule by more than 30 minutes. So I think we'll shorten this phase unless I am advised otherwise. I don't know whether Dr. Kihara is still with us. Can she make a comment on this?
I am certainly here. Some of them are just comments. A lot of people are asking about the presentations. We must get consent from each of the presenters, then they'll be uploaded to KNH repository, so you'll be able to access them from there. Other than that, I think we can just extend by maybe an extra 10 minutes so that people can leave by at least 5, but we don't have anything after this session for this day.
Thank you so much, Dr. Kihara. So I think I'll just go through a few of the questions which have been asked. And I want to start with the first presentations. There was
Lucy, can I ask a question and then you continue?
Yes, do.
Now, I'll make an observation. The Kenyan law says a child is all the way to 18 years. And within the Sexual Offences Act, we do clarify that people who are children don't have the capacity to consent. I've had a chance to look at some of that adolescent data that is used to push that adolescents are sexually active early. And I think we need to relook at our data and agree that our data collection is in line with our laws. The median age at first sets now for our adolescents, at least the last data I looked at, was actually 18, 19 years. So we are grouping the data of young adults, so people who are over 18 years, with data of children, people who are 15 to 18 years. I think we need to separate this. We don't have to always follow the rest of the world, and then actually address the problems as they are. Two, being in school, staying in school is a very good way of keeping people out of a lot of trouble, structured environment. So I throw that out there as something to think about as we have the rest of the discussion. So thank you. So Lucy, you go ahead and conduct this session of question and answer.
Thank you so much. I don't know who will respond to Professor Duarte's question, but I think 2 or 3 of the presenters can do that. In the meantime, I want to address questions specifically to Sarah Gitome, which she presented on HIV prevention. And there was somebody who was asking about the intimacy. After taking the PrEP, how long would they stay before intimacy? Then there was another question on injectables for ARVs, whether they are available, because she talked about injections for PrEP. Then the side effects of Carbotegravir, to comment on what they are. Then there was another question on oral preparation and daily use. Would one have to use them daily for PrEP? Then there was one on if one had planned exposure, how early they should initiate the PrEP, and whether the use of condoms was still necessary. I think we give her a chance to answer, then we go to another presenter.
Thank you. Thank you very much, Dr. Kabare. I've noted down the questions you have asked. I think one of the questions is asking about when does PrEP become effective? the oral PrEP. So what the studies have shown is that the maximum protection will be attained for different days for different kinds of sex. So if it is anal sex, and especially receptive anal sex, then it looks like the drug concentrates earlier in those tissues. Hence, after 7 days of use, consistent use, then one will have maximum protection from PrEP. However, for vaginal sex, the drug takes a bit longer to concentrate in those tissues. So maximum protection will be achieved after 21 days of consistent use. Then in relation to that, somebody asked whether for the oral PrEP, one needs to take it daily, and the answer is yes. So it has to be taken daily consistently, and one needs to go for regular risk assessment. So in Kenya, the guidelines are you go every 3 months for a repeat risk assessment and HIV testing. And depending on what the outcome is, one will be cancelled accordingly regarding risk reduction. And then there'll be a discussion on how long you're going to continue with the PrEP. But basically, it should be for as long as you're still at an ongoing heightened risk of getting HIV. And then in relation to that, somebody asked whether one still needs to use condoms, and the answer is yes, because PrEP does not protect you against other STIs. So one still needs to use condoms if one is engaging in high-risk sexual behavior. And then also, of course, if you've started taking the PrEP and you're going to get exposed before it has reached the number of days required for it to be effective, then you need to use condoms so that you can ensure you're still protected before the PrEP kicks into effect. Then lastly, about Carbotegravir, it's not yet available in Kenya for use as an injectable PrEP. Like I mentioned, it's still undergoing FDA review so that it can be marketed for PrEP, but it is already FDA approved for use as an antiretroviral drug, and it's being used in some countries for that. So what they are seeking now is approval to use it as pre-exposure prophylaxis. In terms of side effects, what most of the studies, what they were reporting were injection site reactions, so a bit of pain and swelling, then also headache, nausea, vomiting, those kinds of side effects. So mild to moderate in intensity. I think I've answered all the questions. Please let me know if there's one I've left out.
Thank you. I think you have answered most of the questions, and the rest, the other people can probably add to what I probably missed out. Then there was one question to, this must be Catherine Ngugi, on adolescent and youth STI. Factors influencing spread of HIV in Homa Bay. Why are they different from in Nairobi? Why are there different statistics? And I think that's the only one I got from that section, unless somebody else got something different to add on. We'll invite Catherine to answer.
That was a section that was presented by Dr. Ngugi, and Dr. Ngugi had to leave the session. But certainly, if you look per population, the incidence of new infections in Homa Bay is very high, troublingly high. But one would have to look at other statistics, like are the girls, are these youngsters in school? Are parents sending their daughters out to engage in transactional sex? Are there pimps? You know, just like you have drug traffickers, you have pimps. Is there that sort of stuff going on? Are there, you know, what are the belief systems within the peer pressure groups? I've done some work. We've done some, MD pediatric students have done some work in Kisii, which is next door. And one of the cluster of cohorts we did was around adolescent pregnancy, the baby of the adolescent mom. Usually they're high-risk babies, and one of the takeaways was that abstinence is never discussed. It's not on the table. People talk of safe days, and there's misinformation about what is safe days, both among the health workers and the community members. So you're being told the safe day, but it's actually the day you will get pregnant. There's also a lot of poverty, and parents go far away from home to you rent chambers very far away from home, and you leave your children alone. So these young adolescents alone to mind themselves. So there isn't somebody who's guiding them. There isn't somebody who's actually following up and finding out what is actually going on. And then there are other parents who actually send their children to engage in transactional sex and bring food home. So maybe those might explain some of the problems you see in those very high incidence areas.
Thank you, Prof, for answering that. Then we go to presentation by Professor Geshenge. I think I didn't get a direct question. There was only one comment, which was more of appreciating the...
He should answer my question about this, age of consent and your splitting the data of children from those of young adults, and the concept of pushing contraceptives to people who can't give consent. They can't give consent. They are not legally allowed to be given consent for sex. We don't give them. They can't drive. They can't get a driving license. They cannot vote. But we want to include them in that, sort of that cluster of adults, just because other people do it. I think that maybe Dr. Geshenge should actually talk about that, and maybe also talk about with the high prevalence of. It's good that you have family planning and people space their children, but what about the problems of infertility, long term, and also when do we agree that our population is okay? I mean, what is our target in terms of population growth rate vis-a-vis having workers going forward?
Okay.
As you have seen, there are many parts of the world where today they don't have workers, so they are they are great places to immigrate to. Yeah.
Thank you, Professor Duarte, and for that very loaded question. I'll answer what I'm able to do. But to start with, I think your observation is correct, that if you look at the median age of sexual debut, the first time people have sex, DHS of 2014 was about 18 years. And our data from performance monitoring for action is about 17.4 years. So clearly the challenge there, and I'm asking my team to reanalyze the data, looking at 15 to 17 and 18 and 19, and we see what is the difference in terms of prevalence of sexual experience for those two populations. They are likely to be different, and I agree with you that the age of 18 is considered age of majority, and therefore persons can give their consent. Now, the bigger question you have raised is a question of if an individual is sexually active, for whatever reason, are they eligible and should they be afforded an opportunity to access and use family planning? If you go back to the Constitution 2010, it clearly affords every Kenyan the right to reproductive health, and the reproductive health has been defined therein to include provision of contraceptives. In the case of a person who is not planning a family, we use contraceptives. And so the criteria there would mean that this person is sexually active. We know the consequence of sexual activity. We know we are unlikely to stop that sexual activity. We can try, we can cancel, we can do all the things we want to do, but we also know, like the colleague from what's called the psychiatrist mentioned, once an addict or is an addict, it's unlikely that we are going to reverse that sexual episode and the sexual episodes thereafter. And therefore, the need then to afford these individuals a protective mechanism. And so, looking at the totality of the events they are in, then one would be guided by our documents, which so far have defined persons who are eligible to access and use family planning or contraceptives, individuals who are sexually active. You need to have fulfilled that condition. But remember, there's no program which promotes people to be sexually active when it is not the right time for them to be active. But it happens. And this is a discussion we have been having in terms of even the bigger question of an adolescent who is 16 years and for unfortunate situation has become a mother. That person has been described as emancipated minor who, for purposes of reproductive health, is able to access and use contraceptives and family planning. But that, from the legal definition, legal interpretation, that still person is a minor. And so there are contradictions between practice and law, which at some point will need to be resolved. That is why I said I'm not able to answer that particular area because I'm not a lawyer, but there are clearly contradictions in terms of practice and the law. In terms of really, can these persons give consent to use contraceptives? They can. But what is, and you asked a question which is again very fundamental. What is the consequence of using family planning at a very early age? Because you're talking about infertility and other related. Again, on the balanced scale, you would appreciate that individuals who are using dual protection, contraceptives plus condoms, will prevent themselves from having STIs. Using the contraceptives only, the risk of infertility is nearly zero. There could be, but the risk is minimal. And therefore, the bigger problem is sexually transmitted infection exposure in very young persons. And there is appropriate counseling which is provided to individuals who are going to use contraceptives, because again, not every contraceptive is usable for all age categories. So adolescents will have short-term methods, and because their needs are very short-term. And for that reason, then that's most reasonable methods to use. I think for me, that is my response, but there are areas where persons from the areas of law and practice would need to, but I think the government documents as they are currently do allow individuals who are sexually active to access and use contraceptives, and they are supposed to be provided information appropriate for them to be able to make the choices. Thank you. I hope I have answered the question to some extent. I know it may not be satisfactory because the legal part, I'm not able to answer that part. Back to you,
Thank
Chair.
you so much, Professor Geshenge. I will reduce the number of questions we are going to respond to in interest of time, but there are at least 2 or 3 questions, one to Dr. Josephine Omondi on what extent are rehabilitation centers accessible and appropriate for diverse groups of adolescents, including those from rural socioeconomic groups. What I think this question is asking for is availability of rehabilitation centers for those who are in the lower socioeconomic status. Then another one is on how do we help a person on drugs who is denying that they are using, yet all the signs are there. So I think Dr. Omondi will respond to those 2 while I read for Dr. Joguna the last question.
Sorry. Yes, the first question was about what extent are the rehabilitation centers available. Now, I can only talk from what I know, and this is an area where the government has, they say our public hospitals have not done very well, because in the public hospitals, we are only talking of Mathare Hospital, which has a rehabilitation center, but then it does not cater for the adolescents and the youth. it only caters more for the adults. So we really don't have. KNH, we still don't have a rehabilitation center. So majority of the rehabilitation centers are either NGO based or private based. So that is a big gap, and it is something that needs to be done about it. How do we help a person who is denying, although there are obvious telltale signs of substance use, but is denying? Very difficult. However, the hope is at some point, the substance use will take the better part of the person. They will have an effect. And so we take advantage of the time when the person has had a problem, and then we'll start working from there. But somebody who is not motivated, for sure, it is not easy to help that person. And those are the ones we struggle with for many years. So I don't have a straight answer. Thank you.
Thank you so much, Dr. Josephine Omondi. We are going to ask the last question to Dr. Joguna, and this is from Anthony Wanyoro, who is asking you to comment on substance abuse among special groups of adolescents, such as displaced populations, teenage moms, and also if there are any differences between urban and rural adolescents.
Yeah, so thank you. I think that's a very good questions, looking that when you talk about the adolescent and the young people, even if it's the same age cohort, we may look at various other factors within that age cohort, like you mentioned, persons who are displaced, persons who teenage pregnancy or teenage mothers, especially if they're having issues of substance use. Yes, you may need to address these population with some special interest, looking at their special needs. There are a few studies going on, especially at the Nairobi County, is looking at the mental health of the teenage mothers and issues about the mental health in the adolescents. And so probably we'll be seeing a few findings coming out as these studies, their results come out. And these may inform the policies looking at this population. I would say in the area of substance use, as has been mentioned by Josephine, there are quite a number of huge gaps which we really need to look at in terms of integrating the aspect of substance use and addiction-related illnesses as diseases and part of the healthcare. Because for a long time, they have been seen like more of a behavioral issues. They've been looked at issues about to do with crime. And so they have not gotten enough attention and enough investment. And so, yes, it's true, we need to look at these special needs within these groups of populations, within this cohort, and see what really works for them in terms of services. And especially when you talk about the displaced populations, we are looking at how we can address issues of mental health and psychosocial support among the displaced population. Because what has been shown among people who are displaced populations or in a humanitarian setting, they actually go through very stressful moments in their life that may contribute at this critical stage of their life to various challenges in their mental health. And so prevention is very key in terms of looking at mental health and psychosocial support among those settings. And this is part of our policies, and we are trying to set up programs specifically focusing at those populations, and also looking at working with reproductive health and mental health, looking at the needs of teenage mothers and issues of teenage pregnancy, especially to do with mental health. Because it has also been shown they are more prone to impact in terms of their mental health, looking at the various distressing moments they go through, the loss of opportunities, the childbirth at that stage of their life, and the complications which may come with that pregnancy at that stage. And then also subsequent, as you are seeing, most of mental health conditions tend to start at that stage. And then now when you bring issues about complicated issues in their sexual and reproductive health, they may add to those risk factors. Because when you look at any population, you need to look at what are their protective factors to promote them, and then mitigate the risk factors. So actually, I totally agree. That's a very good question where there is work in progress. And I look forward to working with every person here to see that we do something special for the special need for those special population. I hope I've answered all parts of that question.
Yes, thank you so much, Dr. Joguna. I will invite Dr. Ann-Beatrice Kihara to wind up this session. We have only about 14 minutes for the next session to begin. Thank you so much.
Thank you very much, Professor Ruth Duarte and Dr. Lucy Kabare for well-orchestrated moderation. To each of the presenters, I'll say kudos. You've actually brought a lot of provoking thinking. I'll start with where Professor Duarte is talking about the minor, the legal age of 18 vis-a-vis consent, vis-a-vis independence and autonomy of their activities. There's the whole concept coming up, and I think Professor Geshenge alluded to it, about the emancipated minor. And I think we need to take a more critical look in our legal dockets or legal documents, particularly that's which speaks to the Child Act. We have not even captured it. But looking at it even from a sexual reproductive health perspective, increasingly these girls are becoming more mature at younger ages. In other words, the age of puberty is progressively going down, heralded by when do they start menstruating. It's no longer the age 15, which was then the caveat. When you're talking about a reproductive age woman, we used to say between 15 and 49 years. But even as young as 7 years, as young as 9 years. So I agree with Professor Duarte. I think we need to have a rethink. What is the real age bracket we should be contextualizing with the current situation? And again, the disaggregation of data. This afternoon, listening to all the presenters and particularly looking at the data that was presented by Dr. Catherine on HIV, it's coming more and more in the younger age group. Now, we have cultural practices, harmful cultural practices, FGM-C or FGM cutting, that's one. But what happens immediately? It happens, and it happens at a younger age group. Immediately that girl is cut. They are deemed to be ready for motherhood. So the next thing you get is she will end up as childhood marriage or as a child sexually active. So we need to think, what is the culture? Number two, which I think even Professor also brought up, is the issue of poverty. Poverty where basic needs are not being met within a household. Yesterday we even heard, and today again, we are hearing the parental role modeling, the parental provisions for their households, and more so for the children, is pushing even some of them to go outside the box. You're sent by your parent. So again, it makes us rethink what is the role modeling, what is the mentorship, what is the parenting that we should really be pushing as a parental guidance. I think there should be a guidance document. Maybe Professor Ruth Duarte should work on that. Yes, but the last thing I'll mention is this whole element of where do you draw the line between what data is presenting, what is the legislature, and what should be the practice, and who, and therefore, is allowed to therefore give us consent, or who should be deemed to now look more at patient-centered, rights-based care, looking at the individual. So I really am not giving you answers, but I'm giving you provocative thinking so that we actually think maybe the mindset where we say the legal age is 18 and Kenyan's context is beginning to show us that sexuality is happening more and more at a younger age, it cannot be ignored. So do we revise the legal context? Do we use therefore the evidence to inform our policies and advocacy? Food for thought. I'll leave it at that. Thank and appreciate everybody who's been in attendance. I think we've had at one point well over 450, but we want to appreciate everyone who has been with us, and particularly the IT who's in the background and tends to be ignored. We really appreciate what you're doing for us. Dr. Kinuthia, do you have anything to say so that we can essentially then wind up and call it a day? The program for tomorrow has been put up. We do have a lot of interesting issues. And tomorrow we are contextualizing what I'm talking about, the indigenous cultural system. How is it actually affecting adolescent health? I think that really should be one session all of us need to be in attendance of. Then there's the issue of nutrition. How is nutrition in the adolescent, be it under or over nutrition, impacting on the development? I know we've had a lot from Simon and a lot from Josephine. Mental health, cognitive development. It's not just the physical and social, but even the mentation, there is a bearing with nutrition. And what do you eventually end up with when now you add on the added insults of intoxication with drugs? So these are sessions, I'm just going to pick out one or two, but I think you can see even the oncology, that's the cancers that these young people are beginning to manifest with, primarily in the reproductive system and in relation to also acquisition of other viruses, not just HIV, but even human papilloma virus. I think you must be with us so that we can articulate through some of these issues. But thank you, and thank you again. Dr. Kinuthia? Is he there?
Dr. Kihara, I really don't have much to add, just to echo what you have said, to invite everyone to join us tomorrow as we continue with this webinar series. Thank you.
Thank you. Thank you so much. Good night, goodbye. We meet at 2 tomorrow.
Okay, thank you very much. Bye-bye. It's been a great afternoon.
Thank you, Professor Duarte. And thank you, Dr. Kabare.
Yes. Yeah, thank you.
Thank you.
Maybe tomorrow we should have a CT scan showing brain development and when maturation is reached to inform the discussion.
Prof, you should bring that one. I remember you showed it sometimes back. That would be good.
Yeah. Okay. All right then. Have a good evening.